Hello, this is John Kanellopoulos from our office here in Athens, Greece, the Laser Vision Ambulatory Surgery Center, clinical professor of ophthalmology at the NYU Medical School in New York City, New York. Since we're in January still of 2021, wish you a happy new year and go into our favorite subject, keratoconus, and a very interesting cataract patient. Through this very interesting patient, this is a lady who is in her late 60s, 69, and nothing really remarkable here besides a significant cataract, right eye and left eye. This is her September of 2020 evaluation. Things get quite interesting when we look at her tomographies, and this is a standard evaluation for us for all cataract surgery candidates. We can see that she has definitely keratoconus. The silent type, so to speak, we can see is a very central cone, a nipple cone. We can see the back surface much more concave than the curvature evident in the front surface. We can see the truncation of the astigmatism on the curvature maps, and also the thickness maps revealing the cone in the left eye, and also a little bit more asymmetric in the right eye. We can see that this is more typical inferotemporal keratoconus, and we'll see the staging here, stage 1 by the Amsler-Krumach criteria, and stage 2 right left eye. You know that we when we judge keratoconus, we go directly to the IHD 25, 0.025 on the right eye, so not too asymmetric. 48 on the left eye, and the ISV remarkably more in the left eye, 60 right eye, 32. So again, to reiterate all the work that we've done in underlining keratoconus with the asymmetry indices. And here the Optus wide field fundus images that show how significant this cataract was, a very significant PSC cataract on the right and on the left, and how this was making this lady's life miserable. She was functioning with a 20/70, and believe it or not, she was a driver driving. So let's go into the tough stuff. The tough stuff here is calculating an intraocular lens for this patient. And this is a technique that we have reported recently. This is the Tomei interferometry that uses this placido disc topography to give us numbers. And this is one way to do this. We use also the lens star measurements as seen here. And we also use specific topography maps in order to be able, these are the lens star measurements on this patient with keratometries 46.86, 47.99 at 92 degrees. The problem here in keratoconus is the fact that all these devices measure surface curvature and not necessarily the actual cornea power. So we have endeavored into using the pentagram measurements and going into a simulation of topography guided treatment and use those keratometries for the treatment. So just to elaborate a little bit, I know this is very technical. These are all the different keratometries with the different devices. The pentagram has axis 76 degrees, the Tomei 76, the placido 55, the autorefraction 82, the lens star 84. So we have a tremendous difference in the axis and also the amount of astigmatism. You can see here, and this is just the right eye, left eye being worse, the deviations are far more. The axes play between 103, 88, 99, 90, 93, and you can see how different the keratometries are. So what keratometry numbers do we place into our IOL calculation formula, number 1. Number 2, if we are going to use a toric lens, what power lens, what axis is that lens going to go into? So we decided to go with the simulation data from a topography guided treatment using pentagram maps that measure the total corneal power at the 5mm optical zone. And I know you cannot calculate this with your EX500 excimer laser if you're inside the US. You can do that only outside the US. You can go down to 5 millimeters. Inside the US, only up to 6 millimeters. So we on purpose use a small optical zone to take into account the central keratometric, total keratometric power of the cornea. So the numbers here pointed to a T4 toric lens at 84 degrees for the right eye, and a T9 toric lens for the left eye. At T9, I want to underline that, at 93 degrees. Again, the topo-guided simulation with the Wavelight EX500 excimer laser. And I will also add the videos of the procedure, which I'm not sure are any different than what every one of you does on their everyday basis, just a toric intraocular lens implantation. This is her today. We are now 2 months out, and we are an astounding 20/20 uncorrected in the right eye and 20/20 uncorrected in the left eye. And this is brilliant. Here are the numbers. We're gonna look at the numbers in detail. We're at 20/20 plus, 20/12 on the right eye uncorrected. Best corrected 20/20 in the left eye. We have her slightly myopic in the left eye, a mild monovision effect. She is 20/25, and good intraocular pressures, good fundus view, and again, a testament on how these measurements, this novel technique can offer us, even in the most challenging eyes, number one, more accurate total keratometric power, effective power in a keratoconus patient, in order to have a more correct intraocular lens calculation. And of course, due to the deep chamber with these keratoconic eyes, we use the holiday formula of all the formulas available. And then number two, if you're going to use a toric lens, which will obviously address mainly patients who are not RGB contact lens wearers, then the axis, we use a simulation of a topo-guided guided treatment using pentacams in the central 5 millimeters of the cornea, and use that axis suggested by the topo platform and that amount of astigmatism to correct. So hope you found this summary of this patient with an excellent result interesting. We have presented these data in the ESCRS, ASCRS, and AAO meetings the last several years. And please look them up if you're interested to find out more about this technique, and hopefully we'll have it in print soon. Again, good year. This is John Kanellopoulos signing out from our center here in Athens. Thanks so much.